Good afternoon to everybody. I'm Francesca Mallamaci, and I'm the chairwoman of this webinar. The aim of the scope of EuReCa-M is to promote collaborations among European centers, pursuing research in the overlapping area of cardiovascular and renal medicine. I want to remind you, first of all, that participating leave, you will earn one European credit for the continuous medical education. So this is a very good initiative, I think. And this is an exclusive benefit for EuReCa members. Participants are asked to complete a satisfaction e-questionnaire after the event, and they can send it by email. I have an announcement also to give you that the next webinar will be titled GLP-1 in kidney transplantation. Is it feasible? Indications, clinical challenges, side effects, and outcome. And this is scheduled for the March 11. And it is organized by the Diversity Working Group. But now we focus our attention on the webinar of today, and it's my great pleasure and honor to introduce Professor Pantelis Sarafidis, who is our speaker today, and he will speak about the assessing fluid status in dialysis. The question is, lung ultrasound is the emerging gold standard. The panelists who will be with us are José Valdivielso from Spain and Jeroen Kooman from the Netherlands. Please, Pantelis, you can start.
Good afternoon, Mrs. Chairwoman, my dear Francesca. I would like to say to thank again the EuReCa-M and EuReCa for having me here. I'll try to be as short as possible, but give as many details as possible on this important issue. Starting from now, I think you can see my presentation. If you don't, just let me know. So these are my disclosures. And I need to start from a few points that you all know. So as you know, our dialysis people, dialysis patients have a lot of problems. Their mortality rate is extremely high, much higher than that of the general population. They mostly die from cardiovascular causes. And there is a particular pattern of mortality, and we know that for more than 10 years, our dialysis people have an increased rate of cardiovascular events and death. And this relates not to every cardiovascular event, but to arrhythmia and chronic and congestive heart failure. And this rate is increased at the end of the interdialytic, of the long interdialytic interval, that is the first hours of the first hemodialysis day. So is this having to do with volume overload? Of course, this has to do with volume overload. And just if I may go over a few brief slides to tell you things that you possibly all know. So fluid overload is not a good thing. It is a bad thing. It is associated with different problems, blood pressure increase, arterial stiffness, left ventricular hypertrophy, and so forth, and so on. And for quite some time, we know from several studies that fluid overload is associated with mortality. This is a study from Professor Kooman group, who is here with us today. And it tells us a very simple thing, that if you have fluid overload, then you will have decreased survival with this light blue line here. But also, if you have fluid depletion before dialysis, your survival would not be optimal. So both fluid overload and fluid depletion could be a problem. After dialysis, again, fluid overload is certainly a problem, but fluid depletion may not be so. So this gives us some nice data supporting what more or less everybody does today in clinical practice. There are several ways to see this problem. This is another way. So this is the association of intradialytic weight gain and mortality. This is something that you also know. The higher the intradialytic weight gain, the higher the mortality. And there are data for that for quite some time. So if you want to have some insight on that, there are again many ways to see this issue. These are some of our older studies examining what happens over the second and the third day of the interdialytic interval in central pressure parameters. And yet you can see here that the augmentation index is the same in the second and the third day, but this gives a very different result when it comes to systolic and diastolic central pressure. So the third day has a much higher impact on these parameters. And this is not extended, it's extended in other parameters as well. This is more or less a twin study evaluating echocardiography. And as you can see here, again, third versus second day, parameters of left ventricle, same thing, but left atrium volume, right atrium volume, RVSP reflecting what is happening into the pulmonary circulation and inferior vena cava, they are doing much worse over the third day. And of course, everything here and before is volume related. So we should probably stop thinking that the problems with volume come only when one of our patients comes in with a pulmonary edema. The problems with volume overload is every single day in front of us. So what about volume depletion? What happens when we have a patient depleted? Again, this is not a good thing either. Hypotension on one hand, and then myocardial stunning, ischemia of peripheral tissues and of central organs are important consequences of fluid depletion. And there are also several ways to see that as well. For example, this is a typical relationship we all know. Intradialytic hypotension increases mortality, and intradialytic hypotension may reflect from one side volume depletion, but from the other side may reflect this high ultrafiltration rate, which results from previous volume overload. So we have different things here that are more or less associated with each other and are associated with our inability to dialyze people for a long time. So in the majority of our patients, we give them the typical 3-weekly schedule of 4 hours per each session. So all of these things I'm talking to you about were recently summarized in this KDIGO conference report. And more or less this period was something like that. We know that hypovolemia and hypervolemia are bad things. They are related to a lot of morbidity and mortality. And in most cases, they are related to each other. So what we are trying to do, we're trying to have our patients in volemia, but this is a very difficult equation in clinical practice for most of us. So here comes the whole point of this lecture. How do we assess the volume status in the best possible way? This can be translated as the quest for our patient's dry weight, which is a quest that is very old for nephrologists. So you all know what dry weight is. These are previous definitions. More or less is the post-dialysis weight of the perfect euvolemia or slight hypovolemia, so that we can make room for some volume to be added until the next dialysis session. It's very nice to describe these things theoretically, but in practice, we all know that this has a lot of problems. So from the EuReCa-M side, we have said a couple of years ago that we all know, practicing nephrologists do know, that there is no accepted definition of dry weight, and that our reliance on patient symptoms rather than objective estimation is a very important problem. So through the years, we nephrologists have tried to find ways to overcome the situation coming from this inability of our clinical measures to define what is going on. We have used methods relevant to dialysis procedure itself, for example, hematocrit change with hematocrit. We have used some instruments, among which bioimpedance analysis and inferior vena cava diameter were the most common until recently. We have used biomarkers, not a lot of success here, and now we probably would use in the future some artificial intelligence methods, and this is incredible. So the methods we more or less use, you can find here. A lot of people have talked about them. The dilution tracer techniques are the most prominent, the gold standard for volume assessment, but they are invasive, expensive, and at least I don't know anybody that applies them in everyday clinical practice. And even if you use them to assess your patient once, then you do know that in a couple of weeks or a month, the volume status of your the same patients would have changed. So you cannot actually use them in real life. So IVC diameter has a lot of benefits and some limitations. Bioimpedance analysis, I'm going to talk about in a bit. We have used them for a long time, and now lung ultrasound is something emerging. So with regards to BIA, I don't have time to go into detail. Most of us know BIA very well. We use them, at least in my department, we use them more in patients on peritoneal dialysis and in some cases hemodialysis as well. It gives you a nice estimation of total body volume and extracellular body volume. We all know that in several studies, it has been associated with mortality, and this is fine. But when it comes to actual randomized control studies that actually used BIA to identify the optimal weight and see what happens into for outcomes, the results are not very promising. For example, this is a meta-analysis a couple of years ago from Adrian Kovic's group. These are the studies I'm talking about. So mortality, no effect if you use BIA, and again there is no effect in body weight and no effect in change of body weight if you use BIA, and again it's minimal, if anything, effect on actual blood pressure. So these are results that make a lot of people think that you can not be based on BIA in order to really see any association with outcomes. And let's talk about lung ultrasound, our issue today, the new kid on the block. So lung ultrasound as a method is really not very old. So if you have looked like 10 years ago in PubMed, you would only find 52 articles on lung ultrasound. If you look today, you would find almost 1,700 articles. So that's a huge difference. And there is a reason behind that. And of course, I'm not a radiologist, I'm not an ultrasound technician, so I'll give you only some basic principles on that. But there is a reason for people not using lung ultrasound. And the reason is very simple, because lungs have air, and air does not reflect the ultrasound beam. So you just get a dark picture like that, no reflection. And of course, you cannot tell what is normal and what is abnormal. So lung ultrasound has been only used by radiologists or respiratory medicine physicians if they want to do an aspiration of a collection or something like that. However, if you have a solid structure in your lungs, things may change, and of course you don't need to have all these bullets, this unlucky gentleman had here. You can use as an example what you already know if you see a stone in your gallbladder or your kidney. So we do know that if you have something like that, you get a view, a sign like that. We would used to call that acoustic shadow. So you do have a reflection if you have a solid structure within air, and this is more or less the principle of what is going on. So if I can give you some details, imagine you have a solid structure in your lung. This is your ultrasound sensor, your transducer, the ultrasound wave or beam. It goes forward, but then it's reflected backwards, and it gives you a sign. And then for as many times as it reflects back and forth, it will give you another sign. And this is exactly what you can see here, first, second, third reflection, and so forth. And at the end of the story, you get something like that, which is something we call comet-tail artifact, because it looks like the tail of a comet. So having that in mind, one can actually see what is going on in the normal lung. This is a normal lung parenchyma. You can see only a hyperechoic horizontal line here, which is the pleural line, and then in parallel to that, you can see some artifacts, which we call A lines, and this is reverberation artifact. So this is a normal lung. But if you have a solid structure here, let's pretend that this is a mass, this is a tumor in the lung, you get these wonderful comets or B lines. So these artifacts we call B lines, and you can actually count them. This is the basis of what we are talking about. The thing is that any consolidation in the lung can give you these B lines. So this is something that is very important. So B lines are not specific. They don't come up only if you have water. You can have them if you have, for example, an infection, pneumonia, or if you have a pulmonary embolism, or if you have a cancer, or if you have a trauma of the lung. But the point is here, they cannot discriminate, that's fine. But the amount of B lines, the quantity of B lines, is relevant to the quantity of consolidation in the lung. So they can give you a quantification of how things are in your parenchyma. In order to make a differential diagnosis, you should need a CT scan. But at this point, what we need to know is, for what it interests us nephrologists, they can give you a quantification of water. So where are we nephrologists stand? Why are we so interested about it? And in this situation, we have to give credit to our chair today, Professor Mallamaci, who was perhaps the one pioneer in the field. And for me as a nephrologist, I mean, I'm a bit proud of that. I'm very proud of that, actually, because we are in the scientific front line of a technique that more or less has nothing to do with the kidneys per se. So our chairwoman today was initiative a lot of different studies with her group in Reggio Calabria, and the first included a very, very nice description of what I've told you so far. So this is the alveoli, and this is the alveolus here, and this is the pulmonary capillary. Here is where gas exchange is happening, this surfactant layer here. But if you have water, things are different. So this is normal interlobular septa, nothing here, just free air. Your ultrasound beam goes only one way, no reflection. You got the pleura here and the horizontal artifacts. But if you got water in the interface, you got thickened septa, the ultrasound beam goes forward, backwards, etc., and you got these very nice B lines or comets. So this is the principle behind all of it. And if you want to see what's going on, if you have pulmonary edema, this is an X-ray, this is the lung US, this is an X-ray of pulmonary edema. And of course, you will have an image that is full of B lines here. And of course, someone can ask, all right, why do I need a lung ultrasound? I can still have the X-ray. That's a very reasonable question, but we all know that in some cases in the emergency setting, you may need some hours in a busy emergency department. At least this is what happens in my country, to get an X-ray. And second, I don't think that anybody of us would like to give an X-ray in our patient every week or every couple of weeks. So this has something to give us. So is it only nephrologists that make use of that? Of course not. And actually what happened in the last year due to this very sad COVID situation, you will see a lot of research studies and a lot of people using that in the actual emergency setting or in the intensive unit, because it gives you some very good information within a few minutes, and you don't need to take your COVID patient all the way around the hospital for a CT scan and back. So one of the first studies in the area was something like that, a study to differentiate with lung ultrasound people with COPD and people with pulmonary edema coming in the emergency department with the exact same symptom, the symptom of dyspnea. And if you use that, you get a sensitivity of 100 and specificity of 92% in the diagnosis of pulmonary edema. So that was a very straightforward result. So how I do it? So I cannot go into a lot of details, and of course I'm not the expert of that myself, but I really recommend that you see articles like that from Luna Karkani, one of the top experts in the world in lung ultrasound. A very straightforward paper. You just read it over half an hour or an hour, and you cut the whole situation. I'm just going to give you a brief description of how you do it. So there are different methods of doing that, and actually this depends on how many sites you would like to scan. I'll come back to that in the end of my talk, but you can do as few as 4 sites if you are in the emergency department and you are in a hurry. So we actually learned that in the context of the LUST trial that I'm going to talk about in a minute, and we used this method proposed from Zabrik et al. This is a very straightforward thing again to do. We just scan 28 sites in the 2nd, 3rd, 4th, and 5th only to the right side because you got the heart here, intercostal space, following these lines, the mid-axillary, the anterior axillary, mid-clavier, and parasternal lines. So in this way, you get a good scanning of the anterior and lateral sections of the lung. You can actually use any ultrasound device, any 2D scanner, and you can use any probe, a standard abdominal probe, a vascular probe, a cardiac probe, because it's very easy to see them. Low frequency probes are better. So for you and me that we are not experts, we are only used in lung ultrasounds when performing renal biopsies, it's still a very straightforward technique. Is it easy to learn? So for the LUST trial, the coordinators have built up a very nice web-based training, again with Luna Karkani as the main instructor. So several people actually did this training, and here are the results. So 45 nephrologists and cardiologists went through the training, which was a 4-hour video training of how to do this thing. And then these people were actually tested, so they scored some lung ultrasounds that were already scored in advance. And this is how they did. These are the trainees, and this is the expert trainer. And you can see a very strong correlation, close to 1, a correlation coefficient close to 1. So the vast majority of people got it correct. So it's a very fairly easy method to learn. All right, let me give you some idea about observational studies with lung ultrasound, and then I will move to randomized trials. So you can find most of the observational studies in this very nice review from Adrian Kovitz and Associates a couple of years ago. We have cross-sectional studies like that one that associated lung ultrasound findings with other things, and there are also some important prospective studies and a couple of randomized studies in the field as well. So the first study was done by a nephrologist, but it was published in an eminent pulmonary journal, CHEST. It was a single study, so it was the first one, of course, and it had to be single. So these people scanned 45 patients, and this is the number of the B lines. And they also saw that if you scan them again after dialysis, the B lines are going down, which is a nice thing to see. At the same time, however, we have this study from Professor Mallamaci, who of course saw that beta lines were decreasing with dialysis, but there are some other important facts here. So these are patients that, and the majority were normovolemic, euvolemic. And again, with lung ultrasound, you could see that 2/3 of the patients before dialysis and 1/3 after dialysis were actually, by lung ultrasound criteria, were actually congested in the lungs. And the other beauty of the study is that very detailed echocardiography took place. And this was the first glimpse in the fact that lung ultrasound does not give you mainly an idea of total volume overload, because it was not actually associated with hydration, but it gives you an idea of what is going on in terms of water in the critical interface, in the lung interface. So lung B lines, the ultrasound B lines, were associated with NIHA class and a lot of cardiac function and structure parameters, such as ejection fraction, diastolic function, left atrial volume, and so forth and so on. And for me, this is the beauty of this instrument, and I'll come back to that. So what about, a lot of us probably ask what happened to our clinical examination. So in the context of the LUCE trial, this was also tested. And these are a lot of exams, more than 1,000 exams that were published some years ago. And this is our clinical examination. So we nephrologists are a bit arrogant about it, and perhaps we should be. We go over the words to consult other departments, and we are very good in assessing volume overload with a simple eclipse of our eye, or with touching to see if the patient has bleeding edema. But the reality, unfortunately, is not as good. So even in the most experienced hands, clinical signs are not very useful. So as you can see here, this is the categorization by the presence of crackles, no crackles here, diffuse crackles here, or edema, no edema here, very deep bead here. And as you can see, even in the patients which were totally fine in terms of clinical examination, an important amount of people were heavily congested at the lungs. And actually, these clinical signs had a very poor diagnostic accuracy in detecting lung congestion. So areas under the curve, 0.5 to 0.6. So better to flip a coin in the air. And this is another study, and I want to talk to you about this study as well. This study actually assessed more or less 60 sites, because they also studied the posterior sections of the lung. And they found again that before and after dialysis, there were relevant changes in all sections of the lung in terms of P lines, and of course, reductions in total body water. The importance of this study is perhaps this table here that actually tells us that, yes, the P lines are related to total body water, correlation coefficient of 0.34, but they are more strongly related with extracellular water. So again, this was the first one of the first signs that tells us that perhaps these two methods, these two instruments, are complementary to one another. So BIA gives you an idea of the whole volume, but lung ultrasound actually contains both the actual volume, but also it includes heart function and gives you the idea of what is going on in the critical area. So what about prospective studies? There are a few, and they are very good. These are studies, again, from the Reggio Calabria group on dialysis and peritoneal dialysis people, that actually tells us that the higher the B lines, the poorer the physical functioning of our patients, as assessed by this questionnaire. And we should move to more, how can I put it, well-designed studies. And again, I should give credit to Professor Carmine Zoccoli, who has been also an important member of the whole story, as you know, and he's still a very active researcher in Reggio. And he and his colleagues have built this very, very nice study. These are 400 dialysis patients with a very good follow-up. The investigators here divided the population to mild, moderate, and severe lung congestion, 15 to 60 and more than 60 lines. and these are the results. So as you can see here, a clear detrimental effect of pulmonary congestion in all-cause mortality and fatal and non-fatal cardiovascular events. And what is more important is perhaps this figure here, that this association with death and cardiovascular events is independent of what is going on in the patient in terms of age, sex, presence of diabetes, hypertension, even independent of the presence of cardiovascular comorbidity. So lung ultrasound, yes, tells you if your heart functions properly at some extent, but even in patients without cardiovascular history, it also gives you a very strong association. And we have some other important observational studies coming from Professor Adrian Kovics, who was also a named person in this field. This study, for example, was also assessing the association of B lines with mortality, and again, more or less the same picture here, different categorization, but more or less the same picture. But this study also assessed echocardiography and performed multivariate analysis of the major determinants of mortality. And again, the only significant determinants were beta lines and LVMI. And this study was coupled by another study from Professor Kovics' group, which actually assessed in parallel the association of lung ultrasound and BIA with mortality. And as you can see, there is a clear association for both. Lung ultrasound on one side, BIA on another. So the investigators here did a smart thing, if I may. On a model that was predicting predicting overall mortality and included NIHA class, diabetes, CRP, and LVMI, they added separately B lines for BIA results on volume overload. And they saw that BIA was actually adding in the model, so it enhanced the predictive power of the model, but lung ultrasound did not. So this is an interesting finding. Again, probably tells us that these identify different components of volume overload. So moving on to clinical trials. And when it comes to clinical trials, we are all anticipating this trial. This is the LUCE trial. It was built by Carmen Zoccali and Francesca Mallamaci and was executed in many centers, and many of us participated within the EuReCa-M network. This is a very important study, more than 600 participants, a lot of time, a lot of years follow-up, and a very hard primary endpoint, a composite of death, myocardial infarction, or hospitalization for heart failure or acute coronary syndrome. So the study has closed. The results are not still out because data are now processed. We will probably have them in the next few months, and we are very excited of seeing what it is. We haven't yet seen anything. So in the context of this study, the participating centers were quite active, and we have some ancillary studies, if I may, or sub-studies. And one important study, one randomized study, again, came from Professor Kovics' group. So 250 patients were randomized in an active arm and a control arm. This included standard of care treatment. The active arm included a protocol that combined lung ultrasound, and if clinical hypovolemia is present, it also had bioimpedance in a structured way in order to identify dry weight. And with this intervention, there was actually no difference for the primary endpoint, all-cause mortality or cardiovascular events. So this is very interesting. We don't know whether this would be the case for the LUCE study. It may be or maybe not. This is a very important study, but again, it should be considered as a pilot study. 250 patients and a follow-up of 21.3 months. Again, very important results. Another study is what we did in cooperation, of course, with Regio and my good friend, Professor Eckhart from Maribor. We have built a study to see what's going on blood pressure. So this is not absolutely similar to LUST. It's again a bit different because the main inclusion criterion for the patient to come in is to have hypertension. Hypertension was actually identified beforehand with a very strict method. So patients had to be with high blood pressure, and they had 48 blood pressure recordings with this very nice device. This is the randomization scheme, 35 patients in the active group, 36 patients in the control group. And again, control group received standard of care. And if you see the paper and see the actual blood pressures, the blood pressure levels at baseline were about 135. So my point is that control group received really a good attention to volume status. And this is what happened in the intervention group. So we set these limits, 15 USB lines or 5 USB lines, very low for patients that already had cardiovascular disease. And if people in the intervention group were above these lines in the weekly measurements, they underwent a UF intensification scheme to lower dry weight. But this was very gentle, very mild, only 0.2 kilograms per session with a maximum UF rate of 10 mL per kilogram per hour. So these are our results. A small difference in USB lines, about 7, 1.2 kilograms difference in weight, but the blood pressure difference of 6/4 millimeters of mercury, this is not small. This is on dialysis patients, and these are 48-hour ABPM averages. So this is an important blood pressure reduction. However, what I think is the most interesting thing in this study is this one here. These are our complications. And in contrast to previous studies in the field, like the TRIP study, where a reduction of body weight was associated with fistula complications and hypotension, we saw absolutely no vascular access issues. And what we see is that people in the active group, those that had the lung ultrasound intervention, had fewer intradialytic hypotension episodes than the actual patients in the control group, despite this getting the dry weight down. So this is the essence of fine-tuning, finding the people that need to get the dry weight down and get it carefully and gently. Another paper coming from this study is this one, and actually this is the echocardiographic findings published in AJKD. What you can see here is that with this gentle reduction, you had reduction in left atrium and right atrium surface, left ventricle and diastolic diameter, and other parameters related to left ventricle diastolic filling. So an important amount of evidence suggesting that this gentle reduction in dry weight actually with lung ultrasound helps the heart to get less preload and to be more comfortable in its everyday function. So my last couple of slides. What about a singular lung ultrasound? Is there any? Of course there is. So this is again a very recent study published in a prominent respiratory journal, CHEST. 120 patients presenting in a D with the outcome being the heart failure diagnosis, pulmonary edema. So these people compared the 28-point method with the 8-point method, the 6-point method, and even the 4-point method. So just 4 scannings here, here, and on the other side. So this actually takes you less than a minute. And as you can see here, the rock curve, well, it's more or less the same. Of course, the 4 method is not as good, but again, it's not much different. So very good discriminatory power in the acute setting. You just need a minute, much less than all the time you need to do an X-ray. Very, very good. So again, my Regio friends were saying, why don't we just check what we have in our data here? And we had more than 300 patients. So we compared the 28 side scanning that I was telling you about with an 8 side scanning, which is again very simple here. And we found that the correlation was very strong, 0.93. And as we had prospective follow-up of these patients, we also see what the actual risk was. And as you can see here, 28 sites, 8 sites, the same relation, significant relation with overall mortality in univariate and multivariate analysis, and exactly the same thing for cardiovascular event. So if you feel you don't have time, you can just do an 8 side scanning in your patients. This will take you 2 minutes, and you will identify a very important thing. So my conclusions, I think I'm more or less on time. Volume overload and volume depletion are bad things. They are associated with cardiovascular events and mortality in our patients. Defining the optimal dry weight is a complex and hazy, obscure task. Our clinical criteria are not reliable indicators of what is really going on in terms of volume status. The beauty of lung ultrasound is that it can quantify with precision volume excess in a critical area. It's not coming to substitute BIA, it's actually coming to complement the assessment of total body water with BIA. The strengths of this method is that it's very easy to learn, fast, portable, and less technically demanding than other ultrasound exam. It's not echocardiography, it's very simpler. The problem is that it's not specific for water, so if you suspect something else, then you should consult, do a CT scan and consult a radiologist, but it's important if you know your patient and know what you're looking for. The other issue is that it's not helpful for volume depletion. So if your patient is euvolemic, you will see 1 or 2 B lines. If he's volume depleted, you will see again 0, 1, or 2. So you cannot discriminate volume depletion. This is a thing that you will need BIA for. So we have observational studies saying that it has high diagnostic and prognostic value in dialysis. We have some RCTs saying that it's very helpful for blood pressure control and improvement of cardiac chamber dimensions and function in some cases. And what we need an RCT with hard outcomes. We have one that is coming in the next few months to answer whether we should use it as a standard in everyday practice. And with this, I want to thank you very much for your kind attention.
Thank you very much, Pantelis. I think that you presented an exhaustive overview of the lung comets in nephrology, and this is a very important and promising tool in our hands to add together with other tools in assessing the overload in dialysis patients and maybe also in CKD patients, but we don't have still studies about CKD not in dialysis. At this point, I'd like to ask if anybody has questions about this presentation. You can write, chatting, but anyway, we have already 2 questions. The first one is, what do you recommend for standard in dialysis unit? Physical examination only, lung ultrasound, VCI ultrasound, BVS ultrasound ratio, blood pressure, ODA. This question is addressed to Pantelis.
Well, if I was giving nephrology exams, being a resident completing the trial, this would be a very difficult question to answer. So the answer is probably we need everything. We need our clinical judgment. It's no question about that. The problem is that our clinical signs are often, not always, but are often unreliable. Or to put it in another way, we get the clinical signs when the patient goes towards the extreme of volume overload or volume depletion. So I will tell you our experience with lung ultrasound. So we did we did that in the context of a clinical trial at the very first. So we started seeing what our patients were doing. And we had patients that were severely bad in terms of let's say, cardiovascular stability during dialysis. They got a severe hypotension episode every couple of dialysis sessions. So when we actually introduced lung ultrasound and actually quantified what was going on, we have more or less decreased that by great extent. So we do now in routine, let's say, once a month lung ultrasound, and these people do not have any issues. They do not have any hypotensive episodes. The blood pressure came down very, very, very smoothly in all our patients, and we got all this type of patients. We had the ability to identify increased volume. So we had patients that were actually, we have a young patient that he was like 45 years old, and we reduced his body weight by 6.5 kilograms, if I remember, without any practical issues. He was a big guy, highly physically active, etc. So this guy, apart from some problems with high blood pressure, wouldn't have any other problem. So my point is that lung ultrasound enables the clinician to identify different scenarios coming from the very ill, old, fragile patient to the otherwise super healthy dialysis patient that volume overload is present. So BIA is a very useful tool as well, but at least to my point, and this is a totally subjective thing, it cannot give you the, how can I put it, it can give you very nice information on the total body water, but this information you may not need for some patients. So for the super healthy patient, it doesn't really matter if you are 0 or 1 kilograms above the optimal weight. This is very important for the fragile patients, but it's not important for the super healthy patients. So these two tools should be complementing each other. And BIA is something, it gives you information that lung ultrasound cannot give you. And this is how Adrian Kovic addressed it. When you get with 0 lines or 0 or 2 lines or 3 lines in lung ultrasound, you cannot tell the difference between patients that are euvolemic and depleted. So BIA can be very helpful there. So I think that if you use both two with clinical judgment, once every month, once every 2 months, you can get very nice information on what to do with your patients.
Totally agree, Pantelis. There is another question. Speaking of gold standard, would imply that ultrasound has been shown to be superior to bioimpedance. Do you have any data to show or to comment?
No, I mean, that's my point, that there are not any data saying it's better or worse. They are both very, I mean, at this point, we have very nice data and we have studies that actually studied that in parallel. So they are both associated with risk. They give us different parts of the equation, and I won't be tired saying that. So if I had to choose one of two in one of my patients, I would choose lung ultrasound because it identifies water where it matters in the lungs, and this is the first step. This is the first thing. So if one of my patients come in one morning and he's a bit dyspnoic, I would prefer to have lung ultrasound rather than BIA, because of the actual information it gives. But they are both very important. So with the terms of gold standard, and I'll stop talking so much. The idea of putting the label of gold standard, at least for this talk, as the chairwoman may know, is just to start a discussion. The gold standard is dilution techniques. There's no question about that. But you cannot have your dialysis patient doing a dilution technique or doing underwater weighing. This is not feasible. And even if you do it, and even if you get the proper information, within a week or so, the whole volume status of your patients would have changed. So for practical reasons, there is no such thing as a dilution tracer gold standard in dialysis patients. I don't know that if anybody have ever used that.
Pantelis, there is another question. I think that it comes from our colleagues who are used to use what we always used to assess the body weight, the overload. And the question was, what is wrong with the good old clinical dry weight assessment? I think there is nothing wrong.
Exactly. Yeah, I totally agree. There is nothing wrong. This is what I'm saying. And I try to put it in the context. I mean, we nephrologists are very good in assessing volume status. I tell my residents starting residency that within like 6 months they will be the best in the hospital. This is really true because we get well acquainted, and our ability to judge is because we don't see only a couple of signs. We see the whole range of signs. But again, even in the best hands, even in the top experienced nephrologists in the world, clinical signs have a limited predictive value. This is something we should acknowledge. It's like, trying to make diagnosis. I remember in the old times, I'm not as old, but I remember like when I was a child, we were waiting to the GP, to the local doctors, and they were auscultating for ages to see if we do have or we don't have anything, because you didn't have an X-ray in every small town or village. Now we have like super CTs. We should not use a CT for everybody. We should trust your ears. But again, the technology is there, and if the technology is there, we may use it. It's a good technology. It's for good.
Okay. Now I call into action Jeroen to see if he has some additional comment to this presentation.
Yeah, thank you very much, Francesca. Yeah, I think it was an excellent, a great presentation, and also of great clinical value. In our experience, some questions come back. What we do is actually using bioimpedance as a kind of a screening method. You have a large dialysis clinic, and in this way you can actually see, it is being performed by the nurses, if patients are in a certain kind of risk zone. And for instance, if you have bioimpedance and which is fluid overloaded, and hypertensive patients which is hemodynamically stable, there's absolutely no doubt that you should decrease dry weight, should decrease the weight. And that's not the dilemma. I think the dilemma, and that's where also lung ultrasound can come in, are for instance in patients who are fluid overloaded by bioimpedance and not hypertensive, or do not tolerate fluid removal well, of patients who have significant residual renal function, with who are little bit hypovolemic on bioimpedance, and you really don't know if you're going to let's say impact residual renal function. And in this way, I think lung ultrasound really can help us. And I think it's also, there was a question coming back from the physical examination, and I think that's absolutely mainstay. And if you just have a patient in front of you, you should examine him or her also in the proper way. But there's also a pragmatic issue. Often you are called to a patient who's already connected to a dialysis machine, who has some shortness of breath, etc. And then it's very difficult to perform this complete physical examination, having a patient sitting again. And then I think the 4-point lung ultrasound it would be an excellent way, if I see it like that. And we're actually also trying to implement this. We have experience with vena cava, which has its drawbacks, but I think to implement next to that lung ultrasounds together with bioimpedance and of course targeted physical examination, I think it's a great asset.
José, do you want to ask?
Yeah, well, just...
Oh, sorry, Pantelis, do you want to reply
well, actually, Jeroen brought up some very important issues, and for example, I was very happy to hear, because I forgot to say something about it. The patient that is actually with a very good residual renal function and has not any particular problems, like apart from perhaps, let's say, a slightly elevated blood pressure, and then you ask yourself, do we need to decrease his dry weight? But I will lose his residual urine fraction. So what should I do? So BIA can give you some, let's say, some information on that, and let's say it's like 0.7 kilograms above the target weight, the ideal weight. So what would you do? I mean, your gut tells you not to reduce the dry weight. So lung ultrasound can give you the answer there. If you get a lung ultrasound and it's like 3 or 5 lines, you will just leave the patient there with his residual diuresis. But if it's like 30, you should reduce dry weight. So this is what I'm saying, and I'm happy that Jeroen has brought it up. We have all sorts of patients with different clinical questions, and if you use them properly, you can get a lot of answers and better.
José?
Yeah, well, thank you. I'm just from the technical point of view. I mean, ultrasounds are affordable, are not invasive, are not irradiating, but they are not so easy. I mean, it's a little bit tricky, right? So I was wondering, because we use ultrasound, we don't use lung ultrasounds because, you know, as you well said at the beginning, air is not so good for the ultrasound. So I was wondering whether the learning technique, how is the learning curve, whether it is complicated, because you show some results. I guess it was for interpretation of the lung ultrasounds. But what about the taking the images? Is there variability? Do they take long for the people to learn? That will be one question. And the second one is regarding the results of the only clinical trial, interventional clinical trial that you showed, that there was no differences. Hopefully, in the last study that you say will be available soon, we might have maybe better results or more with more patients. My question is whether you think there is any kind of a special patient that will benefit more. I don't know, because you showed these results that in hypertensive patients, for instance, you know, the reduction in blood pressure was significant. So do you think that there could be some kind of patients like maybe hypertensive that will be more benefit from this technique? And what about PD? Is there any data on PD, peritoneal dialysis?
Well, thank you, José, for all these questions. So I'll try to answer. I took some notes. So with regards to the learning process, you know, I was also very reluctant myself to see what was going on, and I was talking to Francesca that perhaps I should send my fellow over to Regio, and Francesca and Carmen said, let's see how they do with the video thing. And I started with one of my very good fellows, and he was a very smart guy. So after a while, he said, you know, piece of cake, and I said, oh my God, I'm not sure, would he make it? And then after a while, he was actually doing very well, and I checked with him, and that was fairly easy. And then I let him introduce it to his second fellow, and then the second fellow to another one. So I got, you know, like three or four boys and girls like doing that, and they did it very well. And then the first fellow moved to another department, and then we didn't have the first guy that had the actual learning, but the method is still with us, and it's quite easy. So I'm really voting for a very for the easiness of getting acquainted, and of course. For the cardiologist, it's a piece of cake. For the cardiology fellows, it's a piece of cake. They just take it up in like 10 minutes. With regards to the other thing, we say, okay, I hope that the LUCID is positive, but you know, the BIA randomized trials were not positive, were negative as well. That's an important fact. But even if LUCID is negative, that does not retract for the clinical value. And that comes to your third question. So are there patients that we probably benefit at most? Yes. The patients that we will probably benefit at most are the patients that we don't have any signs or symptoms of hypovolemia. The patients that do a hypotensive episode every single dialysis sessions, we know what to do. The patients that come fluid overloaded every 3 dialysis sessions, we know what to do. But we have a lot of patients that they're doing actually right. The blood pressure is not that bad, but it's like you do a 48-hour ABPM, and it's a bit high. This is a patient that actually can benefit a lot. This is the patient that we were talking with Jeroen, the one that has residual renal function. Is a patient that will benefit a lot. So about PD, because I think that's another question. So we recently reviewed this issue with a dear friend of mine, Olga Balafa from Ioannina, that is a very good PD expert and also had very well has been in the LUS study before us as well. So the studies that have used lung ultrasound in PD are only a couple. We don't have any, there are some interesting data, but we don't have any reliable data. But what I can tell you from another study we did is that most of us now would agree that PD patients are not doing that good in terms of fluid overload as we thought they were. So we had a comparative study with hemodialysis showing that they're doing less well in terms of 48-hour ABPM. So to be honest, I would love to see a randomized study in PD patients where the intervention arm would be based on both BIA and lung ultrasound and check blood pressure, for example, to start with. And of course, a mortality patient if it was possible. So I think PD patients can benefit a lot from it as well.
And just to add something, you know that the ultrasound, the B lines are very useful in COVID patients, in COVID-19 patients. And this is a very, very helpful method in the diagnosis of pneumonia in COVID-19 patients. This is a good news, I think. There are a lot of publications right now. And
because this is exactly the point. I perhaps I was not clear. My hospital, we have the COVID wards now on one side and the CT, the radiology department on the other side. So you had like 2 security guards, 2 nurses, the patient, and everybody else blocked out in order for the patient to be transferred to get a new CT. This is a thing that you can do at the bedside in 2 minutes. So the validity of that it's exactly that. It gives you a straight answer, and of course you use your clinical judgment. So it's not straight saying that it's so much used with COVID, and perhaps the respiratory medicine physicians will use it a lot.
Okay, thank you very much. I greet everybody. Have a good night and continue to follow us at the EuReCa-M webinars. Bye-bye.